Hey, future RN. Okay, let's talk about it. Those who do you see first questions on the NCLEX, they can feel so overwhelming, right? It feels like every single option is a priority. But you know what? Today, we're going to make it crystal clear. We're diving deep into stable versus unstable patients, and you're going to know exactly who to see first, every single time. No more guessing. My whole goal today is to give you a secret weapon for these questions so you never get tripped up again. Welcome to ClearPath NCLEX, your go-to channel for high-yield NCLEX content that actually helps you pass on the first try. And hey, before we dive in, if you get any value out of this explainer today, do me a huge favor. If you like the video, like and subscribe for the most high-yielding NCLEX content. Hit that bell so you never miss the next game-changing NCLEX tip. All right, so let's get into it. Here's our game plan for today. First up, we're going to talk about why these priority questions are so tricky. Then, and this is the most important part, we'll unpack the core rules of unstable versus stable patients. After that, we're jumping right into the NCLEX practice arena. This is where we're going to build that confidence. And to wrap it all up, I'll give you a master cheat sheet you can take with you. Sound good? Let's do it. Okay, so let's be real. Prioritization, it's hands down one of the biggest, most tested concepts on the NCLEX. And there's a really good reason for that. This is the skill that separates a nurse who's just, doing tasks from a nurse who is a true critical thinker. It's not about who's yelling the loudest for pain meds. It's about knowing who is at the highest risk of dying, right now. And that's exactly what we're going to master today. So here's the secret weapon I was talking about. You know your ABCs, airway, breathing, circulation, are always number one. But what happens when all four of your patients seem to have stable airways and they're all breathing okay? That's where this framework comes in. The rule is just so simple. The unstable patient is always your priority, period. They're the one who's most likely to crash, and crash fast. All right, let's break this down. It's actually super simple. An unstable patient, that's someone who's going through an acute change, something totally unexpected, or a situation with a high immediate risk of something life-threatening happening. Now, a stable patient, they're the opposite. Their condition is predictable. The symptoms they have, yeah, we expect those for their diagnosis. They are not in immediate danger. See, we're making this so simple. Okay, I want you to think of these keywords as giant, flashing red flags. These are the sirens going off in the question stem. When you see words on your NCLEX like sudden, new, worsening, or changing, your brain needs to immediately scream unstable. And here's a hard and fast rule. Any patient less than 12 hours post-op, always unstable. A newly admitted patient, unstable, because you have no baseline for them yet. These are the folks who need your eyes on them right now. And then on the flip side, you've got your green flags. These words basically give you the green light to see this patient later. We're talking about a patient with a chronic illness who's at their normal baseline, or someone with symptoms we totally expect, like a post-op patient with some pain, or, someone who's already got their discharge papers ready. These are the patients who can safely wait a little bit. Okay, so let's put it all together. Here is the simple 3-step decision rule that is going to be your best friend. Step 1, always, and I mean always, scan for those immediate airway, breathing, or circulation threats. ABCs are king. Step 2, if there's no clear ABC emergency, your very next move is to find the unstable patient. Unstable always wins over stable, every time. And step 3, if you somehow have 2 unstable patients, which can happen, that's when you pull out the tiebreaker. The more acute condition always beats the chronic one. You've totally got this. All right, that's enough theory. The only way to really, truly get this down is to practice. So welcome to the NCLEX practice arena. This is where we're going to build that muscle memory and make this stuff second nature. You are going to absolutely crush these questions. Let's get to it. Okay, let's do this. Question 1. You get report on 4 clients. Who do you see first? Number 1, a client with COPD and a baseline SpO2 of 92%. 2, a newly admitted client with DKA who has a changing mental status. 3, a client with chronic arthritis asking for their PRN pain medication. And 4, a client who is post-op day 2 and is up ambulating in the hall. All right, go ahead and pause here. Think it through. Who's the priority? Who is the most unstable person on that list? Did you get it? The correct answer is number 2, the client with DKA. But let's talk about why. The key word here, the big red flag, is changing mental status. That signals an acute, unexpected neurological change. Now look at the others. The COPD patient is at their baseline. That's stable for them. The chronic arthritis pain is expected, stable. And post-op day 2 up and walking, that's awesome, but totally stable. The DKA patient is the only one actively going downhill. They're unstable. Let's keep that momentum going. Question 2. Which of these patients is the most unstable? Number 1, a patient with new onset crushing chest pain. Or, number 2, a patient with chronic back pain reporting their usual 6 out of 10 pain. Go ahead and pause. This is a straight-up comparison. Who is more unstable? Yes, it's number 1, the patient with new onset chest pain. The keywords here are new onset and crushing. This is unexpected and it signals a possible heart attack. That's a huge circulation problem. It's an acute, life-threatening, unstable condition. That chronic back pain, it's expected. It's stable. See how that works? All right, question 3 is all about post-op timing. Who needs your immediate attention? Is it the client who is 1 hour post-op with a blood pressure of 88/50? The client who's 24 hours post-op with stable vitals, or the client who is ready to go home? Pause and think for a second. What are those red flags telling you? If you picked number 1, you are absolutely right. You've got 2 huge red flags here. First, the patient is less than 12 hours post-op, which automatically makes them unstable. And second, that low blood pressure, that's hypotension. It's an abnormal, unexpected finding and a major threat to their circulation. This patient could be bleeding. They are absolutely the priority. Okay, next up. Who do you see first? A patient with pneumonia who's just scheduled for a routine walk? Or a patient who is experiencing sudden shortness of breath with an O2 sat that's dropping down to 89%? Take a moment here. Who are you running to first? For sure, it's number 2. And this one goes right back to our number 1 rule, ABCs. Sudden shortness of breath and a dropping O2 sat is an acute breathing emergency. This isn't just unstable, it is a direct threat to life right now. That routine walk can wait. The ABC threat wins every single time. Okay, question 5. You've got 2 newly admitted patients. First, a patient with newly diagnosed diabetes, but their vital signs are normal. Second, a patient with heart failure who now has new crackles in their lungs and has gained 2 kilograms overnight. Go ahead and pause. They're both newly admitted, so what's the tiebreaker here? The clear priority is the heart failure patient. And here's why. New crackles and a sudden 2-kilogram weight gain, that's over 4 pounds, are huge, unexpected signs of acute decompensation. It means fluid is backing up into their lungs. This is an active, unstable breathing and circulation problem. The diabetes patient with normal vitals is stable for now. Question 6 is all about post-procedure risk. Who do you see first? A patient who's just gotten back from a bronchoscopy or a stable patient who's back from a routine CT scan? Take a second. Which one of those procedures carries a bigger risk right now? The priority is absolutely the patient who just had the bronchoscopy. A bronchoscopy involves putting a scope down into the airway, right? That carries a potential risk of something called laryngospasm, where the airway just slams shut, or even bleeding. Even the potential for a life-threatening airway problem makes this patient unstable until you lay eyes on them and make sure they're safe. Okay, let's try an OB question. Who do you prioritize? A client at 9 weeks gestation with severe nausea, or a client who is much further along at 34 weeks with nausea and constant epigastric pain? Pause here for a moment. What's an expected finding versus what's a major red flag in pregnancy? The answer is number 2. Now, severe nausea in the first trimester is awful, but it's an expected finding. We call it morning sickness. However, constant epigastric pain in the 3rd trimester is a massive, unexpected red flag. It's a classic sign of severe preeclampsia, which can lead to seizures. This is a life-threatening emergency for both mom and baby, making this patient extremely unstable. All right, last practice question. Let's head over to the psych unit. Who do you see first? A teen with ADHD who hasn't slept in 2 days? A patient on risperidone who has a new fever, muscle rigidity and altered mental status? Or a patient on sertraline who's reporting a headache? Take a moment on this one. Which of these is a true medical emergency hiding in a psych setting? The absolute no-question priority is patient number 2. That specific combination of symptoms, fever, rigid muscles, and altered mental status in a patient taking an antipsychotic should make alarms go off in your head. It points directly to neuroleptic malignant syndrome, or NMS. This is a rare but deadly medical emergency. This patient is critically unstable. You guys did amazing with those questions. Seriously. Let's wrap this all up now with your master cheat sheet. These are the rules that are going to stick with you all the way to your exam and beyond. So here it is, your cheat sheet. Let's look at the red flags and green flags side by side one more time. In the unstable column, you've got all those red flags: sudden, new, changing, acute, post-op less than 12 hours. Those are your see me now words. And in the stable column, your green flags: chronic, expected, unchanged, ready for discharge. Go ahead and screenshot this, write it down, whatever you need to do to burn it into your brain. And don't forget your little mnemonic to make it stick. Let's say it together. Unstable equals urgent. Sudden, new, changing, worsening. See them first. Stable equals safe to wait. Simple as that. And just to drill it in one last time, here is your final decision-making rule. Number 1, always, always, always look for your ABCs first: airway, breathing, circulation. Number 2, if there's no ABC problem, you pick the unstable patient over the stable one. And number 3, if you need that tiebreaker, acute always, always beats chronic. You've got this, I promise. Thanks so much for hanging out with me today on ClearPath NCLEX. Now, I want to hear from you. Drop a comment below and let me know which who does he first scenario still confuses you the most. I promise I read every single one, and it really helps me make videos that are perfect for you. Just remember, you're doing amazing. Keep practicing, keep pushing. You've so got this. I'll see you in the next video. And hey, if this helped you out, smash that like button, subscribe, and let's pass the NCLEX together.